Assalamualaikum. So our topic of discussion is cardiovascular system pathology. First thing to discuss is congenital heart diseases. In congenital heart diseases, we have right to left shunt and left to right shunt. So in right to left shunt, there is truncus arteriosus, transpositions, tricuspid atresia, teratology of Fallot, and TAPVR. So, one by one, let's discuss this. In truncus arteriosus fails to divide into pulmonary trunk and aorta due to lack of aorticopulmonary septum formation. Most patients have accompanying VST. Now that can be your MCQ. Next, we have transposition of great vessels. In transposition of great vessels, due to failure of aorticopulmonary septum to spiral without surgical intervention, most infants die within the first few months of life. Now, next we have tricuspid atresia. Tricuspid atresia has absence of tricuspid valve. In teratology of Fallot, it is caused by anterior superior displacement of infundibular septum. Most common causes of early childhood stenosis are pulmonary infundibular stenosis, right ventricular hypertrophy, overriding aorta, and VST. VST is basically ventricular septal defect. We will discuss this on later. Next we have TAPVR. TAPVR stands for total anomalous pulmonary venous return. That's not important. And next we have Ebston's anomaly. In Ebston's anomaly is associated with tricuspid regurgitation. That can be your MCQ. Accessory conduction pathways and right-sided heart failure can be caused by lithium exposure in utero. So next we have left to right shunts. In left to right shunts, we have acyanotic, lateral cyanotic. First patient will be acyanotic, then it will be cyanotic in later stages. In left to right shunt, we have ventricular septal defect, atrial septal defect, patent ductus arteriosus, Eisenmenger syndrome, coarctation of aorta, congenital cardiac defect association. So, in ventricular septal defect is the most common congenital cardiac defect. In atrial septal defect, distinct from patent foramen ovale in that septa are missing tissues rather than unfused. Patent ductus arteriosus, uncorrected PDA can eventually result in late cyanosis in lower extremities. Eisenmenger syndrome cause late cyanosis, clubbing, and polycythemia. Age of onset varies. Other anomalies we have are coarctation of aorta and congenital cardiac defect associations. Next we have one of the most important topic is hypertension. Hypertension defined as persistent systolic blood pressure greater than equal to 140 mmHg or diastolic greater than equal to 90 mmHg. Risk factor increases with age, obesity, diabetes, physical inactivity, etc. Most common features are 90% of hypertension is essential primary hypertension and related to increased cardiac output and increased total peripheral resistance. Remaining 10% are secondary to renal or renovascular diseases such as fibromuscular dysplasia. What is hypertensive urgency? Hypertensive urgency is severe hypertension that is greater than equal to 180 by greater than equal to 120 mmHg. Now, what is hypertensive emergency? Severe hypertension with evidence of acute and organ damage. Predisposes to cardiac heart failure, atrial fibrillation, aortic dissection, aortic aneurysm, stroke, chronic kidney disease, retinopathy. Next, we have hyperlipidemia signs. In hyperlipidemia signs, we have xanthomas. Xanthomas are related to skin. These are plaques or nodules composed of lipid-laden histiocytes on skin. And then we have tendinous xanthomas. In tendinous xanthomas, lipid deposits are in tendons. And then we have corneal arcus. In corneal arcus, lipid deposits are in cornea. Next, and here is the diagram to show various anomalies of shunt, VSD, ASD, patent ductus arteriosus, and transposition of great vessels. Next, we have arteriosclerosis. Arteriosclerosis is hardening, thickening, loss of elasticity of arterial walls. It has different types. Arteriosclerosis common affects small arteries and arterioles. Medial calcific sclerosis uncommon affects medium-sized arteries, and atherosclerosis very common disease of elastic arteries and large and medium-sized muscular arteries. Its location is abdominal aorta greater than coronary artery, greater than popliteal artery, greater than carotid artery. Risk factor is smoking, hypertension, dyslipidemia, diabetes, age, more common in men. Symptoms are angina, claudication, but can be asymptomatic. Next, we have aortic aneurysm. Aortic aneurysm is basically dilatation of aorta. So, in aortic aneurysm, it is dilatation of aorta. It has two types, abdominal and thoracic. Abdominal is associated with atherosclerosis, and thoracic is associated with cystic medial degeneration. Next, we have traumatic aortic rupture and aortic dissection. Traumatic aortic rupture is due to trauma or decelerated injury, most commonly at aortic isthmus. And aortic dissection is longitudinal intimal tear forming a false lumen. Next, we have one of the most important topic, ischemic heart disease manifestations. In ischemic heart disease manifestation, we have angina, coronary steal syndrome, sudden cardiac death, cardiac ischemic heart disease, myocardial infarction. So let's discuss it step by step. Angina can be stable, vasospastic, and unstable. There is decrease ST in stable angina, increase ST in vasospastic, and in unstable angina there is T wave inversion as well. Then we have coronary steal syndrome that has stenosed vessels. Then we have sudden cardiac death. It has long QT syndrome. It involves long QT syndrome. And then we have chronic ischemic heart disease, progressive onset of heart failure over many years due to chronic ischemic myocardial damage. Here's the table. Stable angina, ischemia due to fixed atheromatous stenosis of one or more coronary arteries. Unstable angina is by dynamic obstruction of coronary artery. Myocardial infarction is necrosis caused by acute occlusion of coronary artery due to plaque rupture. Heart failure, myocardial dysfunction due to ischemia or infarction, dysrhythmia or sudden death, altered conduction due to ischemia or infarction. These are clinical manifestations of coronary heart diseases. Next, we have with us myocardial infarction. Now, in myocardial infarction, we have ST segment elevation, MI, ST, MI, and we have non-ST segment elevation, MI. That is important from MCQ's point of view. In ST segment elevation, we have increase in ST and have Q wave, transmural infarct, cardiac enzymes, Timing is 0 to 24 hours, dark mottling 1 to 3 days, hyperemia 3 to 14 days, yellow brown softening, and 2 weeks to several months gray white appearance. In non-STMI, there is decrease in ST segment and subendocardial infarction. In myocardial infarction, biomarkers are raised. Next, we have ECG localization of STMI. Here is table that describes this topic. There is another table from USMLE for localization of STMI. These all are MCQs, so note it down. Next, we have complications of myocardial infarction. Complications of myocardial infarction are impaired contractility, tissue necrosis, electrical instability, and pericardial inflammation, in which we have pericarditis. Next, we have cardiomyopathies. It has different types: dilated, hypertrophic, and restrictive cardiomyopathies. Dilated cardiomyopathy is most common in 90% of cases, often idiopathic or familial. Hypertrophic obstructive cardiomyopathy is 60 to 70% of cases are familial, autosomal dominant. Its finding is S4 systolic murmur may see mitral regurgitation. Dilated cardiomyopathy findings were S3 systolic regurgitant murmur, dilated heart on echocardiogram, balloon appearance of heart on CXR. This is your MCQ. Next, we have restrictive infiltrative cardiomyopathy, that is post radiation fibrosis. Our next topic is heart failure. We have two types of heart failure: left-sided heart failure and right-side heart failure. Here are symptoms of left side and right side heart failure. Note them down. Next, we have types of heart block: first degree, second degree, and third degree heart block. This table is from Escaples. And it has, in second degree heart block, we have Mobitz type 1 and type 2. I added this table because there were few MCQs from this table in Rabia Ali. Then we have shock: hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock. Then we have bacterial endocarditis, and then we have rheumatic fever, that is an inflammatory disease that affects brain, skin, joints, and heart. And then we have inflammatory disorders of heart in endocarditis, pericarditis, and myocarditis. Endocarditis is infection of endocardial surface of heart. Pericarditis is focal or diffused inflammation of myocardium, and myocarditis is inflammation of pericardial sac. Next, we have syphilitic heart disease. Organisms spread to various organs causing lesions or gumas. We have primary syphilis, secondary syphilis, and tertiary syphilis. Then we have vasculitides of large vessels, medium vessels, and small vessels. Large vessels have giant cells and Takasu's arteries. Medium vessels have polyarteritis, Kawasaki disease, and Burgess disease. Small vessels has Wegener's disease, polyangiitis, Beckett syndrome, IgA vasculitis, and Schrödinger syndrome. Next, we have cardiac tumors. Here you can see myxoma. Here you can see rhabdomyoma, composed of spider cells. And then we have telangiectasia. Next, there are some MCQs highlights of CVS pathology from Rabia Ali. Then you can note them down. These are most important MCQs from Rabia Ali. You can take its screenshot as well. Next we have errata of CVS pathology from Rabia Ali 5th and 6th edition. All other MCQs are correct. There is no need to confuse yourself. So write them down. Thank you.